This conference will now be recorded.
Hi, everyone. This is Len Sierra for AnCan's high-risk, recurrent, and advanced prostate cancer video chat for Monday, March 17, 2025. Happy St. Patty's Day. So I'll be moderating today with a little help from my fellow moderators here, Dr. John and Rick, and all of our well-informed attendees. We want to acknowledge and thank our sponsors, and they are Bayer, J&J, Myriad Genetics, Novartis, Telix, Blue Earth Diagnostics. And since we have two new fellows, I'll start with Ed Lafrancois. So, Ed, tell us how old you are.
I'm 64.
Okay. And where do you live, Ed?
I live in southeastern Connecticut.
Ah, what town?
Dale. Part of Montville.
Say that once more.
It's part of Montville. I live in a town called Oakdale. It's part of Montville.
In Connecticut.
Yes. If you know, do you know about Mohegan Sun? The casino?
Oh, yeah, way out east. Okay. Yeah, southeast.
Yeah.
Right, gotcha. Okay, I don't know that part of the state too well.
Okay.
Maybe Dr. John does. We have a couple of Connecticut residents here.
we don't know how to say Connecticutians or whatever it is.
All right. And so you said you heard about AnCan through a friend?
Yes. Lou Gett.
Someone who's an AnCan member?
I believe he still is, yes.
What's his name?
Lou Gett.
No.
No? Okay.
You're very welcome anyway, with or without him.
So, Ed, when were you first diagnosed?
I was diagnosed in April of 22. I had gone to my primary care for a follow-up, and at that time I had some discoloration in my semen, and he said, okay, let's go to a urologist. And I went to him, and he did all the tests and did an exam and found a nodule. So he said, well, let's do a biopsy. And there went active surveillance. 6 months later, I did it. He had to do another biopsy because there was a change in the nodule and a scan, and it all started from there. Then 6 months later, I had surgery.
Did they tell you what your Gleason score was?
A 6.
Oh, well, no. Well, can I just add to that a little bit?
Yes, absolutely. I'm sorry, what was your name? Tell us again.
Lisa.
Lisa?
Yes.
Okay. Go ahead, Lisa.
On his first biopsy, it was a grade group 1 at Gleason 6. And when he had the second biopsy 6 months later, because the nodule felt larger to the urologist, and by the way, Ed's PSA was never elevated. That was not the red flag. So anyhow, the second biopsy 6 months later, the cancer had changed character to intraductal with perineural invasion. And let's see, we sent the slides to Jonathan Epstein at John Hopkins at the time. And he had it as a Gleason score 8, 4 + 4, 8.
Oh.
And carcinoma in 4 cores. Let's see what else here. Gleason score pattern 4. And he had a PET scan, and there was no spread on the PET scan, the PMSA PET scan.
And no spread beyond the prostate.
That is correct.
Correct.
Yeah.
Right. Okay. Good.
He also had at that time his urologist, or they had him go to a genetic testing, and he didn't have the BRCA1 or 2, but he was positive for this ATM mutation.
I'm having a little trouble here. You said he was positive for BRCA?
No.
No, not positive for BRCA. Yeah, ATM mutation.
ATM, Len.
All right.
Yeah. And so the things that stand out are the intraductal, perineural invasion, things like that. He had surgery at MSK.
What did you say the PSA was before the surgery?
It was low. I don't have that in front of me here. It was low. It was nothing that stood out.
All right.
Yeah, but low can be important too, Lisa.
Yeah. I don't have it right in front of me.
All right,
there.
you'll tell us later.
Okay.
So he had surgery in 2022.
2023.
Oh, 23. Okay.
March of 2023.
Okay. So 2 years ago.
Yeah.
And
at Sloan Kettering.
Sloan Kettering. All right. Who was the surgeon there?
After a day.
Ah, yes. Okay. Very nice guy.
Yes.
Very good surgeon. And so what happened after the surgery?
Well, I went like everybody else. I've been gone to blood work every 6 months. Then we switched to 3 months because it was starting to creep up a little bit. And just recently it went up to 0.22. So next month I'm scheduled for another scan, blood work, a follow-up with him, and then radiologist at the end of the month.
Right. So no treatment after the surgery. Is that right? Okay. And so they were already planning salvage radiation therapy.
Yes, with some
Okay.
hormone.
You're having that done in West Harrison and Westchester?
It's undecided.
Undecided at this time. I'd like to stay a little more local if I can, but if that's our best option, we will go down there.
Oh, that's right. I forgot. You're in Eastern Connecticut. So what about Yale? I know it's still far, but not as bad as Westchester.
Right, not it's the city, yeah.
Okay. I think there's a Dr. Isaac Kim over there who does surgery. Oh, that's right. You don't want surgery.
No, we already had surgery.
Yeah. So radiation at Yale, I don't know any names there. Do you, Rick?
I know Dr. Yu, but he just left there last year to come up to Hartford.
It's funny, we're near Hartford.
Hartford's close.
Okay.
Should we look into a medical oncologist to add to it also, or just stick with the radiation oncologist?
I think it's you should probably get a medical oncologist on your team. As even though you're planning to have the radiation, you should also have a medical oncologist.
Okay. Yeah. Would you suggest someone, whether through MSK, we have appointments. So far, who's the doctor that they gave you?
Hazelink.
I'm going to leave the recommendations to Rick. He has them all at the tip of his fingers there.
So the medical oncologist they assigned you was who?
Oh, they didn't assign a medical oncologist yet. They just assigned a radiologist.
Oh, they just assigned a radiologist. Okay.
Yes.
And have you seen that radiologist yet?
No, not until the end of next month.
Okay. So let's start with the medical oncologist. Given your location, here's the issue with MSKCC. The two medical oncologists that are in Westchester are fine, but we think there are much better medical oncologists at Memorial Sloan Kettering.
Yeah.
And so, for example, we just had a new person in last week. He's not here today, and we've redirected him from Westchester to York Avenue. As far as where you are, I would say you have a choice of three locations: either going into the city, going to New Haven, to Smilo in New Haven, or going to Smilo in Greenwich, which is probably the closest to you, is it not?
No, New Haven would be.
New
Yeah.
Haven would be.
Greenwich is in western edge of Connecticut, and he's on the opposite end of the state.
They have another smaller location in Waterford. Smilo has a place in Waterford, which is 20 minutes from us. But I know the main hospital, of course, is New Haven, and that's about an hour.
I think if you're going to go to Waterford, you'd might as well go to Yale.
Yeah.
New Haven.
And if you're going to go to Yale, I will throw it off to Dr. John.
Well, I don't know any radiation oncologists at Yale anymore now that we've been lucky enough to snag Dr. Yu from them. Medical oncologists, there are several genitourinary medical oncologists at Yale. As far as I know, you can't go wrong. The most senior person there is Daniel Petrolak, who's my doctor.
Yes.
He knows everything, but you won't get much hand-holding from him. And if you want a better person that maybe spend more time, have better bedside manner, probably get one of the people that he trained that are there. But I can always call the nurse practitioner that I see at Yale and ask for a recommendation, unless you want to go with the most senior guy, Dr. Petrolak.
Might be a
John, is Petrolak in New Haven or Greenwich? I thought he was in Greenwich.
New Haven.
Oh, must have moved.
It's who is it in Greenwich from
Dr. Rowe is there now.
Your guy is in Greenwich. No, Petrolak's not in Greenwich. I don't know if he ever goes out there to see patients.
Yeah, Dr. Rowe in Yale now, New Haven. So.
Yep.
I don't ever remember Petrolak being in Greenwich, Len. I think he's always been in New Haven.
No, I saw Petrolak in Greenwich.
Really?
For a consult, but that was a good 7 years ago. You know, a lot can happen in 7 years.
He might have been the only show in town back then. I don't know.
Yeah, possibly. Joseph Kim is a GU medical oncologist in New Haven. Somebody you can consider.
What was the last name?
Kim. But his first name is Joseph. Isaac is the surgeon. Joseph Kim is the medical oncologist.
Oh, okay.
Do we know him, Len, or do you just know the name? Do you know people who've seen him?
Yeah, a few guys in my Us Two group in Connecticut have seen him, and they like him.
Great. Okay. Well, there you go.
Yep.
Well, a question: how difficult is it if we're working with MSK that we switch hospitals? Is that going to affect anything as far as like what our because we're working with our surgeon still. He's making the recommendations, I guess, of the radiologist at MSK for us to see.
I would say this: if you're going to make the change, now is the time to do it. And probably it's also going to mean that you would need to switch to a radiation oncologist at who's in the Yale system. So it may be that they have somebody decent in. Did you say Watertown? Is that the place close to?
Waterford.
Waterford. So they may have somebody in Waterford, but I think it's going to be a bit tricky if you try and split the radiation oncology and the GU. You could do it, but
yeah. Also, we didn't know the level of care, the equipment for the radiation. Is it different at MSK than it would be
At Yale.
At Yale?
Probably not. I don't know specifically, but I can find out what the Yale equipment is.
There are very specific differences to radiation treatment in terms of you've got both high dose and low dose brachytherapy.
Not for recurrence, Gary. We're talking about recurrence here. So with recurrence, it is possible that they'll use brachy. It's very unusual, but there is a possibility that they'll use brachy. There's a possibility that they would use SBRT. More likely, if it's spot radiation to a metastasis, yes. If it is just radiating the bed and the pelvic girdle, probably not. I think the discussion you're getting into is different types of radiation for primary treatment. So let's just go back to Ed a second. My gut probably would, if it's convenient for you. So I have an idea where you are. I used to go sailing right up there in the far east end of I knew a guy who had a boat in the far east end of Connecticut. I'm trying to remember the name of the harbor up there.
Would it be Mystic? Would be Mystic?
No, it wasn't Mystic, but it was the one on from Mystic. It was a littler one.
Oh.
But I'll look it up and I'll tell you. But anyway, but I have an idea where you are, that Mystic area.
Yeah, that's right.
So I would tend to think Yale, either this Dr. Kim, Joseph Kim, or Petrolak, and I would let them determine where the radiation oncology is best. And I would say I would agree with John and Len that between two hospitals like Yale and MSKCC, I doubt very much if there's a lot of difference in the equipment.
I see. Okay.
Should we make this switch before my PET scan, or see what the PET scan does first and then have everything transferred on?
When's your PSMA scheduled for?
April 3rd.
I mean, I think you have time to do it, but if you don't, then I would go ahead. I don't think that they're going to object to a PSMA scan from MSKCC or the reading. Sometimes they do, and they want you to see you. But I would say that when you call up tomorrow and make your appointment, discuss that with whoever's making the appointment.
Okay.
Len, what would you say?
Yeah, I agree with you there.
Are you saying call where tomorrow?
MSK.
Oh,
You
No.
you have the appointment with MSK, right?
yes, we
Yes.
do. Yeah.
Yes.
No, call Yale tomorrow to make the appointments with Yale.
Okay.
I see.
For what? The scan?
For the medical oncologist to get
Oh, okay. Yeah.
medical oncologist on board. And then when you get the medical oncologist on board, you can say to them, I'm scheduled for a PSMA. I'm scheduled to start talking to a radiation oncologist, but I want to switch my quarterback to Yale, and I'd like to know from them where to go and let them tell you. And they're probably going to say, well, we'd rather you came here. I mean, the one thing I think that's significant is that your PSA is at 0.22, so that's not real high. At the same time, since you had a 4+4 with a low PSA, it could be more significant. I mean, I don't want to worry you, but it could be, because we see having a 4+4 with a low PSA can be a red flag. It's something that you need to raise with whichever medical oncologist you see. Yeah. ATM is usually means the cancer is more aggressive. We don't really have a good precision medicine for ATM at this juncture. I mean, there's some stuff out there, but it doesn't seem to work for ATM. It works for BRCA1 and 2, but doesn't work really for ATM. At the same time, there's some other good combinations coming to light right now that you might be appropriate for. But the fact is that when they tested those, they tested them on men who were de novo metastatic and not men where there was recurrence. And we don't even know if you're officially metastatic. Right. Until we see the PSMA, we don't know. Obviously, a day thinks there could be something up there. Otherwise, he wouldn't have. And I'm not as big a fan of O'Day as Len is for various reasons, largely because he dabbles in focal therapy, and that's never really impressed me that much. And we've had guys with O'Day, and we've actually switched him to Loudon and to Eastham. I'm sure technically he's very good, but my suggestion, and Len and John can contradict me, and anybody else, we should open it up in a second, is that I would try and make the appointment with the medical oncologist as soon as possible and let him quarterback you and direct you as to where he wants you to do next steps.
Okay.
Yeah. Yep.
Jim Marshall, you want to jump in?
Yeah. As far as ATM, way down the road, Pluvicto plays very well with, I am told, and with ATM.
Pluvicto.
So,
yeah, don't worry yourself about that right now.
No,
well,
but it is.
A few more things.
It's interesting.
A few other things that were on the post-surgical pathology, and that was that there were cribriform glands, extraprostatic extension, perineural invasion, high-grade prostatic epithelial neoplasia identified. 22 lymph nodes were removed. They were all benign. He had clean mark, and his state was a PT3A due to extraprostatic extension or possibly microscopic bladder neck invasion.
And did they confirm? Did they confirm the 4+4 in the? I expect you're reading from the post-pathology, the post-surgery pathology.
Yes.
And did they leave it at 4+4 or did they change it?
They did change it to a 4+3.
Okay. Was that? But you didn't have that reread. You only had the biopsy reread, correct?
That's correct. Right. Yep.
And the PT and he was PT3A. Okay, got it. That was what I was. I was PT3A as well.
Oh. Okay.
Got it. Okay. And here I am 17 years later. So there's hope for you yet,
So good.
Good. So good to hear.
Jim, go ahead.
Ed, are you a veteran?
No.
Okay, I thank you very much.
So you had some sort of genetic testing, Ed, and you had the ATM. Did they also do what was that germline ATM or somatic?
Oh, I don't. Oh.
Germline, Len. He had germline testing and it
Yeah,
came out with ATM.
Ah,
germline.
right, right. And do you know if they did somatic testing, which would mean genetic testing on the tumor itself?
No, they did not.
No.
And also, he did not have a decipher test on the first biopsy. They weren't able to complete it. There was not enough tumor volume, and I don't even see it on the second biopsy either for the decipher.
You don't really need the decipher. That would be giving you information as to how aggressive your cancer is. You already know it's aggressive because you have uh, intraductal cribriform.
Uh-huh.
So
All right. So,
yeah,
but that goes to having the tumor tested as well. That is called, what kind of a test is that?
somatic genetic testing on somatic genetic testing on the actual prostate tissue.
Could we at this point have MSK ask MSK, or do we wait on that?
Well, I wouldn't ask MSK for two reasons. One is because they use their own proprietary testing, and the other is because it takes a heck of a lot longer with MSK, usually, not always, but usually. Again, I would leave it up to your. The thing is that the only tissue you have is 2 years old, and it could be done, but it's really up to your GU Medonc whether they want to pursue that or they don't. Could it affect treatment? I mean, what we say here is don't get a test just for the sake of getting a test. Get a test if you think it can affect treatment. Okay. Could the results of that test affect your treatment? Maybe, possibly, but it's a bit of a maybe. You know, this new trial results, Len and I touched on it, basically suggests that an alternative for a man, for you, might be something like enzalutamide and a PARP inhibitor called talazoparib. The issue is, well, there's a bunch of issues. First of all, it hasn't been approved yet. It's in for approval, but it hasn't been approved. So could your doc get it approved? And then secondly, there's a lot of issues as to whether you even want to consider doing a PARP inhibitor up front, because 64% of the people that were in that trial finished up with blood issues, because the PARP inhibitor tends to make you anemic. And so, you know, there's pros and there's cons.
Yeah, he's slightly anemic. He already takes iron at sometimes, right?
Yeah.
And did you get a baseline testosterone measurement?
No.
No.
No, that was a thought to ask for.
Yeah, you should do that because I imagine when you have the radiation therapy, they'll want to give you hormonal therapy along with it.
Are there any heart problems or GI problems like colitis or anything?
No. No.
Good. Let's see, we have some hands up. We have Wes and then Larry.
So I think I missed the diagnosis before the surgery, and I believe you said you also took lymph nodes, and I'm curious about what the biopsy of those showed or why they were taken. Your situation is fairly similar to mine.
Yeah, there were 22 lymph nodes removed, all benign. We don't know why. Clean margins, and just, that's all that we know there.
And the initial diagnosis was via an MRI and a biopsy?
No, it was a biopsy.
Physical exam.
Yeah.
Yeah, didn't he have a DRE?
Yeah.
Yeah.
So they skipped the MRI. Okay. And this is a sidebar for Rick or somebody. I'm being sent to an MRI.
They didn't skip the MRI. He just wasn't diagnosed with the MRI.
Right.
They diagnosed him with a digital rectal exam, and then they went on and they did the MRIs, the biopsies, etc. Wes, if you have an issue for yourself, we have time, so you should. Len, please add Wes to the list, and we'll get to him.
All right.
Sounds good. Thanks.
And Larry, Alaska, go ahead.
Olymp is not talking about treatment, but the ATM mutation has implications for prostate, breast, and pancreatic cancer. So 2 questions in one. Have you got any relatives that have had these cancers, and maybe some relatives who maybe should be alert for the potential?
My mother had breast cancer.
Do you know if she had the ATM mutation?
No, she did not.
Well, no, she didn't have genetic testing.
Oh, that's right.
Back then. But she did have, it was ductal breast cancer, if that makes a difference. That was about it. That's all we know.
Well, if you got any, children or relatives like that, maybe they should be alert.
Yes.
We shared the report with them.
Very good.
Thank you.
And Ed, did they talk to you about diet and exercise?
Oh, yeah.
Okay.
And my assistant here always getting on me for exercising and eating right.
Okay.
Started doing non-dairy, less dairy, knowing that there's a correlation with that. So it's been about 3 months.
That's kind of hard with those ice cream parlors in Mystic, isn't it?
Yeah, it is.
Dr. John, you are up.
So before we go on, I want to know if I have any homework. If you'd like me to call my few contacts at Yale looking for a medical or radiation oncologist at Yale, let me know. Actually, you can write to me. I'll put my address in the chat.
Okay.
Any other questions for us, Ed and Lisa?
No, I think that's it.
No, we just got homework to do ourselves. We'll have to wait for John to send along some names and recommendations, and we'll go from there.
Okay. Well, we hope you come back.
Yes, we will.
Tell us.
It's been super helpful.
Very good. Very good.
Do we have have you signed up to our list? Do we have your email address and everything else?
You did sign up, so you should have it all.
Okay. If you signed up on our website, you'll be in there. Can I just add that we have some other groups that might be of interest? I don't know.
Okay.
We have a men speaking freely group, which is for men only to talk about anything except your actual treatment. We have a women speaking freely group that happened earlier on today that is for women to talk about, including care partners, to talk about anything that's on your mind, excluding, and some of that will be to do with some of it will with the women speaking freely, it'll cover care partner issues and what have you if you want it to. We have a care partners group. We have, and I will add you since you have an ATM germline. We have a group we call BRCA Brothers, which is just right now a distribution, email distribution to people who have a significant inherited mutation. Your mutation is not as significant as BRCA2. It's probably more significant than BRCA1. And so if there are issues around like telling your kids and stuff like that, that stuff gets raised in there. And we're going to be starting a quarterly group for all those guys to meet together and ladies to meet together. So I'll add you to that BRCA Brothers distribution. And then we have wonderful art class, and we have a wonderful creative writing class, which are sort of part of our mental health programming. If you'd like, if either of you consider yourselves to be artists, or even don't, because the lady who teaches it is incredible. I understand they're going to be drawing aliens on Thursday. It happens once. Aliens for Thursday.
Our daughter happens to be an art teacher.
Okay. Well, she's welcome too. And you can go online and you can look at the gallery. Unfortunately, that class runs up at the same time as Men Speaking Freely, or the second Men Speaking Freely of the month. So none of us guys seem to see it. I don't know. Anybody ever attended the art class here? I bet that's a no. Oh, Dr. John, how was the art class?
Fantastic. It's a great deal of fun.
So we'll make sure you get an art class reminder. And if you fancy yourself as a writer, you can join the writing group too. But the point, I think the point is that we try to be holistic. We talk a lot about diet. We talk a lot about exercise and stress management. And these classes are aimed, they're not prostate cancer specific. They're chronic disease specific. And so we try to support that.
Okay, great. That's awesome. Thank you so much.
Okay, well, welcome to the group, and we'll see you next week, I hope.
Yep.
We're going to move on to our next new member, Gary Austin. Gary?
Yeah.
There he is. Okay, let me go through the questions, Gary, okay?
I'm sorry?
I'm going to go through questions, and you answer them as I ask them, all right? Just to keep us on track. So how old are you, Gary?
80.
80? Very good. And where do you live?
I'm in San Francisco.
Ah, okay.
So I don't know much about Connecticut.
That's all right. That's not a requirement to join the group. Let's see. How'd you hear about AnCan?
I probably heard of it in one of my other support groups, possibly the one that was in the Walnut Creek cancer support community.
CSC.
S2 group.
Yeah, but specifically run out of Walnut Creek.
All right. So, Gary, when were you diagnosed, and what was your PSA and Gleason score?
I was first diagnosed in 2008. My PSA was rising, got up to about 8.8, at which point I was supposed to pick a treatment. I was not in a support group, and I was a mess.
Do you remember what your Gleason score was?
3+3. 2 cores positive.
Okay.
One of the cores was listed as only a partial core.
Okay. And so did you have surgery?
No, I had what I believe is 3D conformal.
I didn't hear you, Gary.
I had 3D conformal.
Oh, okay. Yeah, the old radiation.
Yeah, it was a while ago. And it lasted about 8 years until my PSA started creeping up. So they watched it until I got up. It got up to 4, and then they said you've got a recurrence. I'm in Kaiser, by the way.
Okay.
And at that point, they said you've got a recurrence. And I was advised by a medical oncologist who is now my doctor to go with intermittent Lupron therapy, which lasted, I'm going to say, about 2 years until I failed that. And I am currently on Lupron plus abiraterone plus prednisone. And for 2 years on that, my PSA remains undetectable.
Okay, very good. Who is your medical oncologist and what institution?
At Kaiser in San Francisco, her name is Andrea Harstark.
Ah, yes.
Okay. And I have a specific question.
Sure, go ahead.
Okay. My problem has to do with incontinence. Urinary incontinence, I have made a lot of progress, both taking what used to be called Myrbetriq. It's now, I think it's available generically as Mirabegron or something. And doing Kegels since about December. And I've been making a lot of progress, I thought. However, I have one problem which shows up periodically. My wife swears that it's been, my wife doesn't like it. It swears that it's been about 3 times or so in the last month or 2. And that is that I have the feeling that I'm going to have an urgent bowel movement. So I'm heading to the bathroom. And we live in a small house. Our house is 1,300 square feet. I'm heading to the bathroom, and suddenly I lose control of my bladder. And that's a problem because it happens. I've been, with the Kegels and the Mirabegron, I've flipped away from just depends. But when that happens, it's like I'm in the middle of trying to pull my pants down to sit on the toilet, and suddenly I'm peeing all over. And it's a very specific thing. It does not happen all the time, but it does happen. And when it happens, it's a mess. And I don't know if anybody has any experience with that, because this seems to be something. I'm not basically having bowel urgency. I take my gastroenterologist put me on a combination of Metamucil plus a half of an Imodium tablet every day. And so I've been following that. And it seems like I generally don't have bowel urgency, except for these things which show up as I've just described them.
Gary, when did the urinary incontinence begin?
Oh, I don't have my wife here. Sorry.
Was it long after the radiation treatment?
Oh, yes. Yeah, it began to start maybe around the time that my PSA started going up, which would have been about 2016, and it got worse, and then I started in with the Myrbetriq and the Kegels, and then it's better. It's not. It hasn't changed the frequency, but it has changed the urgency.
Yeah. I don't know. Should we turn this over to our medical doctors? Dr. Jack, Dr. John?
Well, Gemtesa, we've talked about often enough in this group as a fairly good drug of choice with people who have urinary urgency and incontinence. I don't know if you've ever given it a trial. GEMPESA.
GEMPESA.
Yeah. Yeah.
T for Tommy. We'll put it in.
G for George.
Yeah.
Kaiser doesn't use Gemtesa.
Yeah, Kaiser. What
They
you
use
want?
Myrobetriq, which works great for me, but Kaiser won't use Gemtesa.
Yeah. It's too expensive for Kaiser.
Myrobetrix's $500 for a 90-day supply.
Wow. It should be down now because it looks like it's gone generic.
I got that one last month.
Yeah, it's recently, yeah.
And if you're on Medicare, which I'm sure you are, the cap is now $2,000 in copays.
Well, I'm covered under my wife's medical insurance, and I'm not too sure exactly the details, but for what used to be Myrbetriq and is now called Mirabegron, I'm paying only about $10 a month. We pay overall for the insurance some amount, but with that, the Kaiser drug costs are quite low.
Gary, have you seen a urologist about this issue?
Yeah, I have I talked to a gastroenterologist and she said, no, talk to your urologist. So I've got an appointment with him to talk to him later in the month. I'm basically, most of the time, I'm quite satisfied, except for these times that just show up seemingly out of nowhere.
Larry, you want to comment?
Yes. Yeah, I'm not talking about a medical solution. I'm talking about a physical solution. So I've been facing this problem for quite a while. And it's very interesting because sometimes I can be active for 2 or 3 hours and feel no urgency or nothing specific. Or driving, when I'm driving, like I can drive up to 2 hours with no need to urinate. But the second that I get to my apartment, walk up the stairs before I can reach the toilet, I am ready to pee myself. This happens in situations where I start to realize I have to go to the bathroom kind of abruptly, and it's very hard to make it to the toilet. So, I mean, I use a variety of techniques for myself. One of them is I do something physical, something else that takes my attention to get there. Like I do some kind of physical aggressiveness, which whenever I'm doing anything physical, I don't have to worry about urgency.
Physical aggressiveness?
Well, I could do like run or lift a weight or do something else to do something that takes my mind off the fact that I'm on my way to the toilet. And get my blood pressure up or get myself active and then go eat. It always, I get upstairs the second I lock my door, I immediately feel, oh God, I have to get to the bathroom. And then I go to take my jacket off, my pants off, and get to the bathroom, and damn, I have to take my underwear off and throw them in the wash, and sometimes clean up like you're saying. So I use a number of methods to deal with that. First of all, I carry a kit, what I call my kit, which is I have a little bag that I keep the pens in and
Yeah.
the change of underwear and some wipes.
Yeah.
And I carry that with me when I'm traveling. Going. The second thing is I take whatever you call those urinary, the thing you pee into when you travel.
Yeah. Okay.
I
I
keep one
have.
in the trunk and I
I
keep
also
one
have a
in my
penis
bed.
plant.
But basically I've 95% solved this problem, only very occasionally. And then I've discussed this before. I use a method I call double tap, which is when I feel I have to go to the bathroom, I go and then I wait a minute or two and go again and enter my bladder. Like just 2 minutes later, I can finish emptying my bladder as best I can. That's what works for me, and I've been living with that for many years since radiation, since uh, chemotherapy, and I mean I've solved this. I go to work. I have regular underwear, but I carry my kit with me, and I make sure every couple hours to go to the bathroom, even if I don't feel it. And I stop along the way when I'm driving, but I carry a kit with me, my kit with me. And I'm able to go to work. I'm able to go to the gym. I'm able to go with my life. It's just as soon as like you were describing, as soon as I get near the toilet when I haven't been to the bathroom in a while, the urgency becomes extreme, psychological kind of it. When you know, you're going to go, now you only have a few seconds before you can run into this incontinence problem.
And I know that feeling.
So I do something physical. It's like if I come in my apartment, I have second I put my luggage down, oops, now I have to be in the bathroom in 5 seconds. So I may not put my luggage down. I may run to the other room to get my clothes off and just be active and take my mind off the fact that I'm running to the bathroom to pee. If I can get my mind off it, then I can make it.
Okay.
That's my physical experience with this issue for many, many years. And I can't solve it except by, managing to get to the bathroom often enough and doing double tap. Like when I'm driving, I stop in the middle of the road 2 hours. I stop and I go to the men's room and then I wait like 2-3 minutes and I can finish emptying. And then I can complete my trips. Like I drive 4 or 5 hours every week, twice a week. So I carry my kit. I follow these things. I carry a little thing you can be in case I'm really stuck somewhere or the traffic is really bad. I stop the car, get out, walk to the other side of the door, open the door, pee into the thing that I also keep under my bed. It's not very frequent. And
Okay, sounds like you two guys have the same issue. You should exchange phone numbers or emails or something.
that's the whole story. There's nothing else really much to say besides the fact that
Okay.
I found this is the method I use rather than expensive
All right.
medications.
Okay, thanks, Larry.
Len, should I make a comment?
Hold
Go
on.
ahead.
Alan,
Yeah.
Alan, put your hand up. There's two
Oh,
people.
yeah. Let me go to Jeff Markey first,
All right.
Alan, and then John, and then you. Go ahead, Jeff. Jeff Markey, what happened to him?
He's muted. He's trying to talk.
Oh.
Yeah, you're muted, Jeff.
Oh, shoot.
Start
Gary,
again.
did you have salivary radiation? It didn't sound like you did.
No, I have not had any treatment.
Well, as a result, you could get. Have they ever talked to you about having the sling put in to stop your leaking problem?
No, I can bring that up.
They've got specialists at Kaiser who specialize in incontinence, and you might want to ask your urologist to send you one of the specialists, and you can talk about a couple of other treatments. I used to have, before getting the Myrbetriq, I used to have a problem when I'd walk around, I'd leak a little bit at night. And what I found was I'd carry a real small towel with me. And if I leaked at all, I just put that in front of me till I got to the bathroom. And so that way I didn't leak all over the place. I don't have that problem now, but I did have it. And it wasn't like I released completely. Though I must admit, it used to be that, I pull it out and I'm leaking as I'm pulling it out. But the Myrbetriq has seemed to have stopped that for me completely. I guess not for you, but like I say, this just carry, it seemed like you said that this problem was happening at home and that you'd had to head to the toilet. Just carry a small towel with you, and that way you can cover yourself if this starts to happen.
That's a thought. What I really wanted to know is, do you know the names of any doctors at Kaiser?
Yeah, unfortunately, it'll take me a minute to bring up the names. I do. I'll put them in the chat. I'll put a couple of names in the chat of there's two different doctors that specialize in incontinence. They were both in Oakland, but that's where they treat you if you have incontinence.
Okay, I just put my email in too, so if you'd be willing to email me.
You may have heard me talking about coming here over at CSC meetings, because I've mentioned it many times. And I also have Andrea Harstark as my oncologist.
Yeah.
A lot of commonalities. All right, well, let somebody else.
John, Dr. John, you have a question or a comment?
Yeah, just to mention, this is called urge incontinence, and it's got different urodynamics than the stress incontinence that you've probably had for the last 8 years or something like that, and different treatments. So you're exactly on the right track, getting to a urologist where they'll use the history and maybe, if you're a little bit unlucky, some urodynamic tests to determine what's going on now and how to treat it. I assume there's no blood in the urine in this new phase, or you probably would have mentioned it. Am I right about that?
Yes, no blood.
Okay. Yeah, urological diagnosis first and then pick a treatment.
I'll bring that up with the urologist I've had for actually quite some time, but I will bring it up with him.
Yeah, get that appointment. I guess you already got it set up. That's just what you need.
Yeah. The strange thing is that it's not all the time. I have bowel movements and they're just, normal. I don't have problems most of my days. And then suddenly out of the blue, I'm in the back of the house where I am now. It's a small house. And suddenly I think I got to go sit on the toilet. And by the time I get to the bathroom, I'm peeing in my pants. And it isn't that far. So I will have to, Larry, I appreciate what you said, and some of it I try. I have thought about carrying when we drive, what do they call those things that you pee into? Take my advice, don't get old.
A urinal.
Urinal, yeah.
Exactly. I guess it's called a urinal. It's like a little, it's like a little plastic bottle with a shape, with a curve in it, and
yeah, I have.
I carry.
Apparently, do you sit in the passenger side when you like park or something, and then just?
Usually, I stand up and I walk. I open the door on the passenger side, and I go do it, standing right by the door.
Okay, facing the car.
I'm driving. I'm the one driving.
Yeah, but
pretty tough to get privacy in Brooklyn, Larry. Huh?
What?
Yeah.
I said pretty tough to get privacy in Brooklyn when you're standing outside the car peeing.
Oh yeah, it doesn't. I have plenty of warning. I stop at
Alan, you have your hand up.
Anyway,
Yes, go ahead, Alan.
So a couple of comments.
I plan my spots.
I had urge incontinence for a couple of years, following radiation. And over the years, it got worse and worse, and the spasms would be really bad. And I managed it for a while with Botox injections. My urologist did that, took away the urges. It was reasonably effective, not perfect, but I was happy. But over time, at least for me, the Botox started to wear off sooner and sooner, and then injections really didn't do much. And then I had complications from radiation, which I got radiation cystitis. I had black blockages with clots in the bladder. And so for me, and I don't say it's for everybody and may not even be indicated by a physician, but I opted to get a suprapubic catheter. And so it goes suprapubic catheter. It goes through the skin right into the bladder. And I wear a leg bag to catch urine. And overnight, I hook up my catheter to a large overnight bag. Now, the beauty of it is it's no bother. I have no urges. I have no leakage. I have no problems. And while it sounds radical, and maybe it is, it solved my problem in a way that really worked for me. I come and go as I please. I hook it up in the morning, empty the bag a few times during the day. I personally couldn't live with urges and unpredictability. That was the thing that was really making me crazy. And it wasn't for me. And so I opted, my urologist suggested this. I was thrilled, and that worked for me.
All right. Thank you, Alan.
Yep.
Let's see. Gary, is it all right if we move on? I think
I'm copying something, please.
Yeah. Jeff put some doctors' names in the chat box for you. Okay. Yeah. All right. Dan Straub, you are up.
Oh, yeah. Can everybody hear me? I just wanted to give an update on the MRI I got last week concerning the hip issues that I had, and I already communicated with Dr. John. I spent this weekend trying to get my head around why the MRI technician used certain terms, and my oncologist agreed with me this morning. The two terms that he or she used was suspicious metastasis or a fracture, insufficient fracture, which is a type of stress fracture. I think we both agreed that instead of getting another PSMA to determine whether it's a recurrence of the prostate cancer, it's probably a condition for me that it's osteoporosis and osteoarthritis, and put off the PSMA until my PSA starts to increase. It's only at 0.01 right now, so it's way before we're considering another PSMA. But it could be, one could be very conservative and say it's necessary to do. I've just decided it's not worth taking the chance, because if it does come out, they're going to have to do a bone density or a biopsy again into the bone. And it's probably better just to give it some time right now. But that's my call and my update on the hip issue that I'm dealing with.
Okay. Thank you, Dan. Any questions for Dan or comments? If not, we will go to...
Yeah, I just want to say something quickly to Dan. Dan, I had hip issues. First of all, I was osteoporotic when I was diagnosed. I was young, but I was still osteoporotic. Secondly, I had hip issues forever and a day. and I just exercised through them. And ultimately, it turned out that I had pretty bad degeneration in my hip, but it was over a period of about 3 years. And never once did I think that it was metastatic disease. I mean, it could have been. I might think of it now, but at the time, even though I was pretty buried in this stuff, it didn't even occur to me. So I'm thinking, if you've got osteoporosis and you've got a little bit of hip pain, that's what it could be. It didn't show, the hip socket didn't show any deterioration?
She didn't say that in terms of deterioration. She just said the insufficiently fracture. And then my oncologist indicated all my previous MRIs and scans showed no bone metastasis at all. So the oncologist is pretty much on target. It's just that in order to be conservative, they were saying, let's do the PSMA. And I think it's premature.
My 2 cents on this, and I have seen the MRI report, is a radiologist, the radiologist that read that thought that it didn't look good from the point of view of possible metastasis. And the oncologist didn't think you had much to worry about. But my feeling is that the change since your last MRI is too fast for me to explain it by osteoporosis. If on the off chance this is metastatic, it's fast. So I kind of cringe a little bit at the idea of waiting very long without either a biopsy or a PET scan. As you and I have discussed, it's possible to have recurrence without a PSA increase. So I just wanted to express a little bit of my anxiety, which stems entirely from reading that radiologist MRI report.
Well, not entirely, because there's the guy, what's his name, at Duke. There's the guy at Andrew, what's his name?
Armstrong.
Oh, Armstrong. Yes. Yeah. Well, that's where I get my idea that you can have a...
That's why I say not entirely, because Andrew Armstrong is one of the guys. What was your PSA at diagnosis, Dan?
14.
14 or 15.
Okay. You know what? You're in the Kaiser system, right?
Yep.
Ask him for a PSMA.
Well, it's already scheduled for next Monday. It's just that I'm thinking I'd pass it on until my PSA raises.
Do it. It'll give you peace of mind. They're going to pay for it. Do it. And if we have more issues, they'll pay for it again. That's the beauty of the Kaiser system.
The remaining question with Dr. John, you mentioned recurrence, and the oncologist mentioned progression. She said it's possible, just like you said, that the PSA could have a progression. What's the difference between a progression and a recurrence?
We tend to, let's say you're on treatment and your PSA is non-detectable. Then all of a sudden your PSA starts coming up again, or a image of some sort, like a PET scan, now shows something. So we would call that a recurrence. Progression just means that your cancer has moved ahead despite treatment. Well, no, not despite treatment. Anyway, if your cancer progresses in any way, that's progression.
Mm-hmm.
John, wouldn't even an X-ray, let alone an MRI, easily determine if there was osteoporosis in that hip?
That's been proven already. They did the X-ray, Len,
Okay.
and I
So,
already when they detected osteoporosis, and last week they gave me a reclast injection. So they already know there's osteoporosis, and I'm pretty sure there's osteoporosis or osteoarthritis.
okay. And so that suspicious spot, how did that compare to, they usually say interval increase, interval decrease between this reading and a previous reading. Was there any such, or maybe I should ask John, I don't know, did you read
I
anything about
didn't,
that in his report?
I didn't see a statement like that, Len, but I assumed since it wasn't mentioned before that the previous MRIs did not show any of this at all.
Okay.
That's what bothered me. But Len is right. You have to compare the two to see if in fact there is.
Exactly, and because the oncologist is aware and had looked at the other one, she said they're not showing any bone scan, but that was a year ago, and then the hip X-ray was just a week ago, 2 weeks ago, and she's on top of all of that.
Are all these imaging at the same facility?
Was within the same Kaiser organization, but different facilities.
But they have each other's records, I assume.
Yeah, it would be under my record, right?
Okay. Yeah, Jim
That
is
doesn't
nodding.
mean, I'm not looking over anybody's shoulder of an MRI tech to see if they're comparing different images. One
It's the
never knows.
radiologist's job to compare previous imaging with the current imaging. I'll take another read at that while the group is going on.
Yeah, in the interim, tomorrow morning, I'll send you a little bit of what she said so that you're aware of that.
I think you already did, didn't you? Mean the oncologist?
Yes, her
Yeah,
comment.
you already did.
Oh, did I? Well, there was some following ones.
Oh, there are?
Some.
Okay, sure, anything.
All right. Thanks, all.
All right, thanks, Dan. David Up.
Alfredo, Dr. Alfredo has his hand up.
Oh, sorry.
I was just going to make a quick comment, Dan, and I'm just a dumb internist. I'm not an oncologist. I'm kind of with Rick on this one. One way to think of it is the PSMA is a relatively non-invasive, pretty harmless test. It takes an hour. I would hate to see you on this call a year from now going, darn, I wish I had gotten the PSMA.
Yeah.
So if you go ahead and have it next Monday, you'll have no remorse. And it doesn't slam the door on any other testing, on any other consults. So my bias would be just go ahead and have it. The worst case is you'll look back and say it was an unnecessary test, right?
Right.
And I'd hate to have you say a year or two from now, I wish I'd gotten that. Going to be more information. And the other comment I was going to make is because you're in Kaiser, Northern California, they all have access to the images. Nobody's going to say, bring me your X-ray from the other building. It's all one system. The radiologist.
This is not California. This is the East Coast, Washington. So it's a little bit different.
It's Kaiser, Washington, D.C. area?
Yeah.
Yeah. Well, same comment. Within that geographic region, they're all seeing the same image. No worries about that. You don't have to haul a piece of film from one building to another. But the other thing is that the radiologist who's reading your images may or may not be in anywhere remotely near Washington. It could be in Spain or Singapore in this day and age. It's a generic statement for all of us. Radiologists can work from anywhere, clearly. But the people who are treating you can see those images and can see those reports, no matter where the radiologist was sitting on the night they read your image. So my bias, like, you get the PSMA, so what?
Great. Thank you.
Shut up.
Just curious, Alfredo, how soon before we see AI readings of radiologies or scans?
Already happening.
It's already happening. In fact, I wouldn't even say it started yesterday. I would say we're well down the path. And in fact, I was in a completely separate context. I was involved in this topic today about AI and multiple industries, and we are way. Think about it. All those calls where you are calling, the voice says, in a few words, tell me what your problem is so I can route you to the right person. We're going to see that more and more and more and more. And the radiologists are going really fast on AI. So you have it. I mean, I can't say we can stop it, but we can be mindful of it.
May not want to stop it if, from what I've heard, sometimes they're more accurate than the radiologist.
That's right. But I think in my lifetime, I'd like to have both. I'd like to be able to say to a human radiologist, what do you think about the AI reading? And maybe over time I'll change my tune, but for the next few years, I'd really like to have access to a human when I want it.
Right. Gary, go ahead.
My comment about AI is I've forgotten the question, but I wrote in a question having to do with prostate cancer in Google, just punched go. And what I got was a bunch of an AI response, which seemed to answer my question very definitely. But then I noticed it was an AI response. And I looked more carefully at what the AI response was based on, and they were pulling things out from all over the place. It didn't look to me like it necessarily had a good, it wasn't talking to a human being. And I'm suspicious about AI coming to conclusions based on a whole lot of papers which are not necessarily related to one another.
All right. We don't want to have a discussion of AI here, but thank you, Gary. Let's see. Let's go to David Opp now.
Okay. I've got an update. About 2 years ago, I had my 5th reoccurrence since the original surgery in 2016. That was a PSA of 6.2, and the PSMA scan found 18 scattered bone mets. They started me on Eligard and abiraterone, and within 2 months, the PSA went down to undetectable, and just the recent PSA or PSMA 2 weeks ago, there was basically no evidence of any disease. So it was no evidence of disease right now. So that the cancer front, I'm doing great on. About 6 months ago, I developed neuropathy in my toes. And when I was at Mayo, I was able to get in with their peripheral nerve clinic. I was seen by 2 doctors there. And they did a very thorough physical exam, and they had done an EMG also, and met with the chief doctor in their neuropathy clinic. And we both kind of agreed the neuropathy isn't from the chemo, which was done over 4 years ago. And I thought it could be from the abiraterone. He kind of feels that the abiraterone isn't causing it, that it is more undetermined cause, and he's leaning toward the fact that it's just simply aging. Because he was saying past the age of 70, about 5% of the people develop neuropathy. So his thought was that it's not disabling right now, it's just a one. And he kind of said, guess what? You're just going to live with it on it. So there's no return visit with their neuropathy clinic or anything, unless it would get significantly worse.
Well, is it painful or just numbness and tingling?
Kind of a tingling, burning, depending on how I step. Yeah, it can get painful, but it's very short-lived pain. And I'm on a farm and a ranch, so I'm active outside yet. I'm climbing in and out of tractors, walking around the yard, working with cattle, sorting, chasing them, and everything. So
Mm-hmm. And
it's
you're not pre-diabetic or diabetic or no.
nope.
Well, I know of several of us, myself included. I know Rick too. We have some minor peripheral neuropathy in our feet, numbness. I think with you too, Rick. I don't have any pain, but I assumed it was from the hormonal therapy. I think Rick thinks so too. But the first time hearing that just being over 70 could be a cause.
I don't entirely agree with that diagnosis. You know, it's
Yeah.
more like the idea that we don't know what's causing it right now.
Yeah. I don't know how they
ride along with that.
I don't know how they can rule out chemo. I mean, that's notorious for causing peripheral neuropathy.
But it was over 4 years ago.
I don't think it matters. I don't know.
Usually it happens during or, slightly after,
Right.
not that long a time period. Because I had absolutely no neuropathy during the chemo.
Right.
Do you have a history of osteoarthritis in your lower back?
I do have arthritis in my back, yes.
Well, that can cause symptoms of peripheral neuropathy, without doubt.
I've had a 3-level fusion in the cervical area. I've had 2 lumbar fusions. So there's been, and I did do salvage radiation and also spot radiation to the T4 vertebrae.
So you've had a lot of things going on.
Yeah, it could be any cause.
I think so.
Okay, we've got.
Plus, you're on the ranch. You're working that back all the time.
Oh yeah, farmers and ranchers are notorious for back problems.
Right.
We have 3 folks with their hand up: Larry, then Rick, and then Jeff. Go ahead, Larry.
On just going back to whether or not to opt for an additional PSMA PET scan, I was wondering how much of a radiation load do you get with a PSMA PET procedure, and is it important?
Anybody want to handle that one? I was wondering about that myself.
What difference does it make? Other than academically, you're going to say, I'm getting too much exposure to radiation.
Well,
but, if you need it diagnostically, what choice do you have?
Yeah.
Can't be much. In the recent little over 2 years, I've had 9 PSMA scans.
I don't think, I think that the radioactive material disappears after a pretty short time.
Right.
Rick, you and I heard the half-life of well, I don't think it's a lot of radiation, and if it is much radiation, at least it's stuck onto cancer cells for a little while.
I guess my only comment would be that the question that we're discussing is more important for a younger person than it is for an older person. And that's, I know, a gray area. I can't say numerically what the dose is, but I can tell you this. The radiation treatment, the 43 radiation treatments that I just had for my prostate cancer was the equivalent in total dose of 70,000 chest x-rays. So going forward, I'm not worried about x-rays or PET scans or anything. Of course, it was delivered over 43 separate days. If I got that same dose on one day, it would be fatal. And the other thing is that you're peeing out the radionuclide pretty quickly. But maybe by the next time we meet, I'll have an answer to what is this equivalent to in terms of radiation. But I think the older you get, the less you care. Is really the main
You're saying it's de minimis.
Yes.
All right. Thank you, Dr. Alfredo. Just a reminder, we have hands up, so make sure you, next time you comment, you put your hand up and we'll come to
Sorry.
you.
Sorry.
And so you're up, Rick.
Yeah, I like Len and puzzling over how they were so quick to discount hormone therapy and chemo, even if they discount the chemo, which might be you didn't have. We know that neuropathy, it's listed as a side effect, but fairly rare of hormone therapy, and you've been on hormone therapy for 4 years now. My neuropathy didn't start until at least a year or maybe 18 months after I finished the hormone therapy.
Okay.
And it's painful enough that it makes me limp. So, I don't think that should be discounted. I mean, I've heard people who complain of neuropathy and they just have tinglings in their fingertips. But what I get is a lot more than tingling. It's like needles being stabbed into me or walking on coals. It doesn't last. It's I shouldn't say it's not permanent. Sometimes in the winter months, because I get it worse in the winter months, it is all the time, but not always at the same intensity. So I'm a little discouraged about how they've swept you out the door at Mayo. Who is your quarterback now at Mayo? Is it still our friend who's talking in a couple of weeks? Yeah. Do yourself a favor. Do yourself a favor. Get yourself over to Elizabeth Heath, will you? Please.
I'm no evidence of disease.
Doesn't matter. Doesn't matter. You are metastatic.
Yes.
And when you deal with, if you to go tell Dr. Heath this is what you've got, she's not going to accept that. And look, Sartor's good. Heath is fantastic as a clinician. She may not, I mean, she does a lot of research. She may not be quite at the level on research as Sartor is, but she's wonderful. And you gotta do it, and do it before it's too late, because God forbid your disease comes back. And it's amazing that the abiraterone has gotten rid of these metastases. But the problem we're faced with is that you're not cured, and the disease can always come back, right? And when that disease comes back, we don't want to be dealing with our friend the surgeon, all right? We want you to be dealing with somebody who we trust. And I would make an appointment. I'd ask for an appointment, go up, have a review of your case, tell her you want to work with her, and go through this neuropathy stuff again and say, I'm just not happy with this resolution. One thing I can tell you with her, she'll listen to you, she'll empathize with you, and she won't just throw you out the door. I mean, by the way, she's now the chief oncologist at Mayo, not just GU. She's they hired her as chief oncologist. And you can tell her AnCan sent you, and then she'll smile. But honestly, David, please do yourself a favor.
I'm comfortable right now,
But you're not. You got this neuropathy that you're not that you're dealing with, right? You're not comfortable. If you were comfortable, I'd say okay, but you have issues. They're not being dealt with right, and you don't have an advocate for yourself there.
I can advocate pretty good for myself.
Well, you let them throw you out the door.
Well, in a way, yes. In a way, no. I mean, they did scans. They ordered blood tests. They're doing more testing on me yet when I go back in June. So, it's not completely don't let the door hit you in your butt.
All righty. Can we move on now, David? Yep.
Yes.
Very good. So, Henry on the phone, are you still with us?
You have a hand up, Len. Jeff.
Oh, yes. Sorry, Jeff Markey. Go ahead.
I was just going to mention, after 4 or 5 years on Lupron, I started getting a little bit of swelling in my feet and some neuropathy. And my oncologist says that, that's just one of the things that happens with the drugs. It is listed under Lupron as one of the side effects. And unfortunately, it comes and goes. Usually it's gone. But I must admit, my oncologist had no answer as to really how to resolve it. Other than, does anybody have an answer for how to resolve it?
Well, I have one thing which, and I wanted to ask. I meant to ask David if he's done it. Have you started taking B6, David?
I am supplementing B12 and alpha lipoic acid.
But try. I recommended this to you because I'm looking at my notes. I recommended that you try B6 a while ago.
My current B6 level is at 11, which is low.
Okay.
Their range is from 5 to 50.
Look, take some B6, okay? It worked for me. It's not going to hurt you, and it may help you. So go down to Walgreens or CVS or Walmart and buy a bottle of the 100 milligram tablets. Try taking one a day to begin with. If it's not enough, try taking 2. Run it past your doctors by all means, and just so that they know, because I don't know what other comorbidities. For me, it was fine. And I will tell you that there are times when I've got up in the middle of the night because it's really been bothering me, and I've gone in and taken a B6, and it's helped me, even on interventional level. So get yourself some B6. I mean, maybe you are taking B12. I don't know what B12 helps with neuropathy or not. I know B6 helps with neuropathy.
They claim B12 does also help.
Okay, we'll try the B6 again.
Okay. I can do that. That's simple.
Right. Sorry. Go ahead, Henry.
Yeah, Henry, go ahead.
Yeah. Thanks. I'm listening really hard to a lot of issues and some of the things like I want a PSMA. My levels have slowly risen. I'm at 0.1 now. I can't seem to get my urologist to make a move and let me get PSMA. According to my pathologies, Decipher, genetic testing, I guess I'm not considered as a high risk on paper, but I had surgery 2 years ago and I do have a detectable PSA, and it has slowly risen. And, I'm also dealing with the VA system. They're a little reluctant to do the PSMA. I have an outside urologist, but I'm thinking maybe I need to go see someone else, maybe a medical oncologist possibly, or just an oncologist, and see if I can get them to move on PSMA. With my levels been at this level, I don't know if it's conducive for me to have a PSMA right now, or that's what I'm being told, that you're really at a low level and it probably won't pick anything up.
Rick, I didn't hear enough of that. You want to respond to
Yeah. Henry, we're getting a lot of feedback from your phone, so it's kind of hard for us to hear you. At a level of 0.1, it's really touch and go. The doctors seem to suggest that, probably at 0.15 to 2. So I don't think you're going to get a lot of sympathy out of the urologist or anybody else.
Okay.
And until you're up around 0.15. And there's no point in sending you to a GU Med-Onc at this point because we don't have any basis to do that. And this is, you're still in the post-surgical phase and the active surveillance post-surgery, which is fine. And you're doing a great job in keeping an eye on it. But I think once you get to 0.15, we can send you some support, and you can show it to your doctors and say, look, we ought to be checking now. But I don't know that you're going to see anything at a level of 0.1. I mean, Dr. John, what would you say about 0.1 and it's 18 months after surgery and the PSA is at 0.1?
My doc wouldn't do it. And he's the one that did the original ARCHES study that Armstrong analyzed that we mentioned an hour ago, saying that you can have a biochemical recurrence. I mean, a radiographic occurrence without a biochemical recurrence. So if even he won't do it at 0.1, I'd be surprised if your doc will.
Right. Okay.
So, I mean, don't give up and keep testing at the 3-month level. But as you get closer and closer to that 0.15, that's when I would be concerned. That's when I would be thinking about getting a medical oncologist, certainly a genitourinary medical oncologist. I wouldn't be dealing with a GU. I think there may be somebody at the University of South Carolina in Charleston. I'm not sure. If your insurance covers it, I'd be sending you to Dr. E in Houston.
Okay. Actually, it's going on. It's 26 months after the surgery. It's 2 years going on 3, I guess.
So here's another thing also to give you some comfort. When we see PSAs creeping up like this slowly and it's taking longer and longer, and this was true, I think, of the other, it might have been Gary, it's encouraging because if in fact it does come back for any reason, then at least we know that it's not a fast-growing cancer and you're likely to respond. The people we're concerned about are the people where it comes back real quick. Like, within 6 months, they've got a problem. So put your mind at rest and don't fret over this because it's going to be a manageable situation.
Okay.
Okay, thank you, Henry and Rick and Wes, San Diego.
No, what about Chuck Snyder? You haven't gone to Chuck yet.
Oh, I must have missed Chuck. Let's see.
He did say yes because I heard him.
Yeah. Okay, go ahead, Chuck. Sorry.
Thank you. So just to give you an update on my Pluvicto treatments, the sixth and last Pluvicto treatment was around Christmas time, and February 4th I had blood work, and it was the PSA was undetectable. So I was pretty happy. I was asking my oncologist what the next step is. After the I have an appointment April 4th, and he mentioned previously possibly doing Jevtana, which is a second chemo. I already did 10 rounds of docetaxel, but he mentioned either Jevtana or excuse me, or Xtandi. But I'm wondering, I've heard that if you have, I did do Zytiga. I did Zytiga, and I did the docetaxel chemo. I've heard that if you after chemo you do Zandy, that you don't respond well. But the opposite is true. If you started with Xtandi, did chemo, and then went to Zytiga, you have a better response. Does anybody know anything about that? Because I'm wondering if, since I've already done the Zytiga and it doesn't work for me anymore, is Xtandi going to work?
Okay, I'm gonna jump right in here and ask you if you read the reminder this month.
What was that?
The reminder before this meeting, our reminder that we send out. Did you read the reminder before the meeting today?
Oh,
the one that sent out on Saturday morning.
You don't give out medical advice? Is that it? No.
No.
What?
Did you read it?
I think I read it. I refresh my memory.
Well, there was a story that Len told in there right at the beginning. It was a lovely story. I loved that story about two monks. Did you read that?
No, I did not.
No. Well, my first advice, and this isn't medical advice, would be to go back and read that story, because it's a very important one for you.
Okay.
Let's just recap, Chuck. You had, how many did you say? Five treatments of Pluvicto? You stopped after 5?
No, I did. I completed 6.
You did 6. And right now you've got an undetectable PSA, isn't that right?
Yeah.
Did they do a PSMA scan as well?
Not yet, but they probably will.
Okay, so I think I'd ask for a PSMA scan, but let's just assume nothing shows on that PSMA scan. God willing. Okay? Live in the moment. I don't want to talk with you right now about what next. I don't know what next. Neither should you be worrying about what next. And should I be doing Xtandi, and should I be doing abiraterone? That's what Len's story was about, right, Fratello?
More or less, yeah. Don't hang on to. It's a little bit reversed for him, but basically, don't hang on to the past, or don't spend your time worrying about the future. Just live in the present moment.
Right.
Enjoy the excellent response you got from Pluvicto, and let's see how long how durable it is.
Okay. Thank you.
The point for you to take home, I think, from this meeting, from this treatment, is that there are a bunch of options. It could be Xtandi. It could be another round of radiation, like RLT, radiation ligand therapy. There are people that are doing that. That could be you could repeat it just like you could repeat chemo. It could be this combination they gave to newly metastatic guys of a PARP inhibitor and enzalutamide. There are so many things that are going on that what's available today may not be the same that's available 6 months from now, and hopefully we're going to get at least a 6-month hiatus. What drugs are you on now?
I'm on Orgovix. I take that every day. And Xgeva, which that's my second question. I've got a question on Xgeva. Yeah.
So you know what I would be looking at? How long can I get by on these 2 drugs before I can get a holiday off of the Orgovix?
Okay.
Now, if you'd have come to me and asked me that, I would have open arms. I have open arms because your PSA is undetectable. I love it. But I don't want you to be thinking, should I get Jevtana? Should I get more abiraterone? Is the edzonulin not so good? I don't want to talk to you about that right now because we don't need it.
All right. Makes
It's
sense.
not that we won't. We'll talk to you. We'll navigate you when the time comes.
Yeah.
But we're not going to let you get to the point where it's gotten out of hand.
Okay. Thank
Fair
you.
enough. Len, why don't you and some of the other people just chime in on this? This is an important point for everybody.
No, I agree with you, Rick. But just to give Chuck a little feedback on what his question was, yes, abiraterone is the sequence when you're talking about the second generation hormonal agent. The sequence that works best is Abi first, followed by any of the others like enzalutamide, apalutamide, or darolutamide. And so you said you had Abi. If it ever came to it, you would probably get some response with any one of the androgen receptor blockers.
Okay. All right.
But like Greg says, don't even think about that now. Just enjoy the good times. Enjoy your undetectable status. And go ahead, Gary, you had your hand up.
I was just going to go along with that. When you get to a point where you've done everything you can or should do at this point, go live. Do something else. You're undetectable. Go out and do something else.
Okay. Thank you.
Right.
Yeah, I just have. Does somebody else have a question? Go ahead.
Two people have questions on there.
Okay, go ahead. Let's see. Larry from Alaska first, and then Frank Chambra.
You're muted, Larry. Unmute.
Thank you. To put Rick's point in a shorter thing is what my mom told me one time: don't borrow trouble from the future.
All right.
But on the counterpoint, though, be prepared.
Right. Yeah, I guess I'm overly cautious. But thank you. That's good advice. Thank you.
All right, Frank, go ahead.
Hey, Chuck. I just want to talk to Chuck for a second. I'm sorry for what you're going through, man. I'm right here with you. I'm at the same place. I'm on my 5th round of Pluvicto. And I don't even care about those questions that you're asking. I kind of cleared my head of all of that crap. I'm just being honest, and I live my life, man. I am so goddamn happy, man, because I'm so blessed, bro. I got 12 grandchildren, a beautiful wife. I play music. I work out. I was gonna go back to the gym today and start swimming. I just did my treatment on Tuesday, but I still feel a little weak today. So I'm a fighter, bro. Shit ain't stopping me. Get that attitude, man. Change the headgear. I just want you to feel welcome here, man, because this is an awesome place, man. And we're all going through it. I see some people you might be here, this person here. I see people like talking, and I was where they were like, 6 years ago. I'm sure you too, right? Whatever. We're all on this journey, man. Enjoy the goddamn ride, bro. Man, watch some Vikings, man, on Netflix, bro. You're a Viking, brother. Come on, man. Let's get this shit on the road. That's it. That's my pep talk.
All right. Thank you. That's good advice.
Thank you, Frank.
Thanks for all the good advice. I appreciate it. But I have one last question. I'm sorry to take up the time. I know it's
all right. Go
10
ahead.
o'clock. But I mentioned I was on Xgeva. I was on Xgeva for about 2 years, and I was initially doing it once a month injections. And then 6 months ago, I switched to 3-month injections. And this last infusion I had 3 weeks ago, I'm just having horrible pain, back pain, and in my ribs, mostly in my upper back, in my ribs, and sometimes in my femurs. And I told my oncologist, and he thinks it's probably the side effect from the Xgeva, but it's been 3 weeks since I've had the injection. So I'm just wondering, does anybody recall having any pain from Xgeva, especially in your ribs or your back?
Anybody? I was on Xgeva for 4 years. I never had any adverse effects from it, but that's just one anecdote. Anybody else here on Xgeva or Zometa? Nobody? Strange.
Okay.
Frank, go ahead.
Yeah, I'm on Xgeva. That's the shot, the bone shot, right?
Yeah.
Yeah, so I mean, my knees I feel some like creakiness in my knees stuff once in a while, but I work out, do leg presses and stuff and push-ups and curls. With lightweight, I swim 3 times a week at the rec center.
Yeah.
That is an amazing thing, man. Like I do water. This is going to, I mean, I do water aerobics with these old ladies, at the rec center.
Wow.
It's good it's good because now I can get out of bed, bro, and I could put my own socks on. I don't know if you have problems with that, but I'm more flexible. So there's other things to do. I mean, here's what I mean, the medicine is doing their part. I got to do my part by eating right, exercising, and anything, just living. And I'm praying that God will add the increase. And that's the way I'm living my life. And I'm not trying to get spiritual on you, but yeah. So
Yeah, the swimming is really good. I was swimming a couple times a week and lifting light weights, but ever since that last shot that I got, I can't do anything. I can't swim. I can't lift weights. So.
Oh, sorry, man.
What did your doctor say about it, Chuck? Did he have any advice on how to deal with that pain?
He didn't. No, he just said he thinks it's probably from the Xgeva, but no. I take Tylenol. Tylenol helps. I take the Tylenol, keeps the pain from being unbearable, but I don't want to live on Tylenol forever. But yeah. I'm assuming it's not metastases because the PSA is so low, undetectable, and the Tylenol seems to help with the pain. So I guess if it was metastasis in my back, I guess it would.
So I want to give Mark Valens a shot because he's going through similar and he may be aware, but we do know it's not uncommon that guys get pain, especially after 3 or 4 treatments with Pluvicto. In fact, there was a paper, and I think I still have it, that was done by a guy at University of Kansas from last year, Genitourinary 24. It was a poster, and I'm pretty sure I kept it. So we know that we often see this. A lot of times it's early in the process, but we've known some guys who get it later in the process, and because there's a lot of bone that is being knocked out and replaced, and it could be from that. So my guess is, and I'm not a doc, but from experience here, it's probably more likely to be the Pluvicto than it is to be the Xgeva. But again, I'm not a doc. Mark, what Valens?
No, I'm on the 30-day Xgeva and I don't have any problems. I just have a friend who was on the 90-day version and he was getting bone pain. He switched to the 30-day and it's been a whole lot better for him.
Wow.
Okay.
Well, there you go. So maybe it is the Xgeva. Maybe it is the Exgiva. Get off those 90-day shots and go back to 30.
Yeah, worth a try. I see
Thank you, Mark Valens.
Dr. John indicates musculoskeletal pains listed 7 to 10%. I presume that is a side effect of Pluvicto, John?
No, that was Exgiva. We hadn't mentioned Pluvicto by the time I wrote that, so
Oh, okay.
that's Exgiva. Pluvicto, we don't have any doubts about, right?
Yeah. Okay.
Okay. All right. Well, thank you. Appreciate the input.
All right, Chuck. Continued good luck to you.
Thank you.
All right, Alfredo, take care. Thank you.
Thank you, Dr. Alfredo.
And Wes, are you still with us? Wes in San Diego.
Well, I can't do better than what Frank said. I'm going to go have a Manhattan with some friends, and then I'm going to go to the pool. You know, pick your poison, balance it out. You only got so many years left. I realize the theme for the 70s is pick your poison. For my eyes, for this, for my, blood pressure medicine, and try not to think too hard, which everyone on this call does, right? The question I'd like you to follow up on maybe next time is I'm interested in different quality of MRIs. That's the question, but not for today. There are better ones, worse ones, and commingling results from one device and another can be problematic. I know that in my geology world. So anyhow, thanks much, everybody. I think we're about out of time.
All right.
Maybe I am.
Now, let's see. Larry in Alaska, did you say you wanted time?
No. And I just want to.
I do
go
have
ahead.
a question about estrogen deprivation therapy, where you turn it on or off. Bipolar.
Hold on a sec. We'll answer it. Hold on a second. Let me just respond to Wes. Wes,
Okay.
the simple response is you don't want to be doing today anything less than a 3T MRI. You don't. Now, how comparable a 1.5T MRI is to a 3T MRI is above my pay grade. I would probably say Dr. Mark could answer that in the low intermediate. I mean, he's pretty knowledgeable on scanning and issues, but the simple answer is you definitely want at least a 3T, if not more powerful. There's a few places around the country where you can get 5Ts now, but don't get an MRI that's anything less than a 3T. And if you compare the 3T to a 1.5T, I don't know how comparable there are. Does anybody know how comparable a 3T to a 1.5T might be?
Yeah.
I've seen the images for both, and like I say, we do this in geology. One's fuzzy, one's less fuzzy. But then, and this is more than probably anyone here, myself included, know, part of it's the post-processing. Part of it's the resolution of the power that you take, and part of it's the post-processing. And you guys are very good at identifying very good people in different institutions, humans. But I think the hardware probably goes along with them. But getting good hardware is what I did, Rick. I made sure my MRI, the very first one, was a 3T because I had no clue.
Right. Well, I'm glad you did, because we've got people in here, one guy in particular who seems to be stuck on getting a 1.5T, and we've told him a bunch of times it's not a good idea. I can't remember if it's this group or if I think it's actually in the low intermediate group.
Richard Fisk, go ahead.
Yes, just as a sidebar, I've had Eurolift, and there is a 3T limit on Eurolift. You can't have any more than 3T.
Okay.
Okay, and we're back to you, Larry.
I just thought I'd bring up BAT just in case anybody had any information. It could be a long discussion. I'm just looking into it.
Okay. All right, guys, we are past our time, so we will end it here. Thanks a lot for all your contributions, and we'll see you next week.
Okay,
Thanks, Len.
Larry, bring up intermittent next week because it is a long discussion and we have opinions on it, including Len, who's probably our expert on IHT. So feel free to ask for time next week and bring it up.
Okay, thanks, Rick. I sent you a message last time about our fearless leader, but I don't think you got it, and I don't have your direct email address.
Okay, my direct email address is rd@ancan.org. And just for the record, since we're still recording, when people send me very long emails whilst I'm co-moderating, it's not possible to read them. Right. It's just a non-starter, and I don't always. It doesn't always download the chat. I don't bother to download it a lot of times, so it's probably not great to communicate stuff like that in the chat. And my email, I believe, is in the reminders, but it's rd@ancan.org.
Okay.
Okay.
Thanks. Bye.
Goodbye, everybody. Joel, don't go away. You're looking very healthy. What's going on?
I'm in Houston.
Oh, you're in
I see
Houston.
Dr. I see Dr. E tomorrow morning at 9:40. I just had a whole